Everybody, time to do another video for you. This one's going to be a great video because there's a lot to talk about. It's one of those things where everything in life is not ideal. Sometimes we get dealt something that's very difficult or compromised to work with, and that's kind of what today's about. It's the compromised tooth, and we love them and we hate them, but we don't want to compromise our care even though the patient is asking us not necessarily to do heroics, but definitely push the limits of what we should or could be doing. So stay tuned. I think it's going to be a great case. And you know what? If there's questions that come up as you watch these things, day or night, I don't care when, just comment below. If I can't answer it, I'll tell you I can't answer it, and I'll find somebody smarter than me to answer it. But let's keep this thing going. And so let's give it a go. Let's pull up this case. All right. So, I mean, as you can see, tooth number 19 is hopeless. I mean, it's gone. It's bombed out, furcation's involved, and it's slated for extraction. We got gingiva growing into the cavity. But you know, 18 had been sort of worked on, and it's very desirable in the sense of it gives the patient the restorative options the patient's looking for. And it could be a bridge or an implant, preferably in 19. But regardless, 18 has some value. And it was requested of the dentist to 19 was going to be slated for extraction in their treatment plan, and 18 was to be saved. And I'm going to show you what that looks like. The x-ray actually does it some justice, but the clinical photos, it's compromised. But that is the treatment plan that was requested of us. And I know you guys all, as endodontists, get dealt cases like this on a daily basis, and we love them and we hate them. We love winning them, but we hate doing them. So let's take a closer look at what this is about. Let's bring in this video feed. So here we go. And I'll just walk you through kind of how I triaged, how I kind of problem solved it. Like I said, there was a lot of, maybe some of you wouldn't actually save the tooth to begin with. I don't know. Tell me if you wouldn't. Comment. All right, so when you look at it, the dentist had already removed the decay, which I love, because that puts the question of, can I put a crown on it on the dentist's shoulders, which is what occurred. So far so good. I got to move this here, get this in focus for you. Here we go. Let's move this up a bit. So I'm removing this, just the IRM that was placed in there. See if I can get that into better focus here. Bear with me. Here we go. All right. So, I mean, 101 stuff, right? I'm removing the IRM, getting it focused. You can see that I did single tooth isolation. It wasn't like I could use the brother up ahead to help with the isolation. And so it raises a lot of questions about how am I going to build this platform, this sound seal platform, or do I abort and just not even consider using the GentleWave? But I wanted to use the GentleWave because I didn't want to compromise on my care in my mind. And so I'm just removing down, and I can even see the prominence, the eminences of the buccal and the mesial and the distal roots. I can start seeing the invagination of the furcation along that buccal wall. I don't like that. It is hard. I already into the furcation zone. It is hard, but I'm already causing exposure. You can see it's hyperemic, so the giveaway is this was an irreversible pulpitis case. And what I just did is I just plugged the hole with caulking and with Formultident. And I do that because it's easy to remove. It's another form of a breadcrumb. And I'll find my way back in there without really having anything to worry about. But what I'm really finicky about right now is the fact that I don't have stability with that rubber dam clamp. And it's gonna slide. Like if I just touch it, even if I think ahead a few steps that I've got to get a platform on there, it's gonna pop off. And it really does need a version of crown lengthening. And so I'm going, dang it, you know, I need stability for this procedure to work. And so it comes to a point where, yeah, I can remove the decay. I see what's left. I blocked myself out of the pulp space, and I'll show you why. You'll see that technique. But I got to stop. I don't like where it's headed. So I'm going to just take a round burr and just do a sort of modified, not really crown lengthening. It is on the buccal, but I'm going to remove some of the gum tissue, some of the tissue tags that were already there from the previous doctor's work, and just kind of some of that ischemic tissue I'm just going to remove off and just try to better refine where where the margins really are of this tooth. It's compromised at this point. You know it is, but it's a very useful, important tooth in the strategy. So I'm going to take some astringent X and just burnish that into the gums and just chemical cautery right now. That's what's going on, and to control the bleeding. And then I'm going to give it another attempt of isolation. And you know what? I think that's the thing we all have to decide. Would we really compromise this first step? And for me, I'm going to go to that degree of stability. And if I don't, that's when I kind of deem it non-restorable. Now, again, remind you, the dentist already told me he's putting a crown on it, and we're going to be having a crown lengthening conversation here. So now that I've kind of adjusted the gum tissue, didn't really remove osseous tissue, just worked with the gum tissue so I could get a better seal around the tooth. I'm going to see if this 2AS, so it's serrated, clamp can get me a nice, tight, strong, solid, single tooth isolation. Say that 10 times. So that's what I'm doing. I'm going to flip the rubber dam down around the clamp, and then I'm going to actually push on the bow and see how stable it is. And I'm also using an Explorer to kind of tuck it into the sulcus, if you will, on the mesial distal, because that's all that's left of the sulcus. The buckle's gone. And this little tag of gum tissue, I'm just going to try to tuck it underneath the rubber dam so it doesn't get in my way, and if it will really expose the entire circumference of the tooth. And that's what I'm going for. So we're going to tuck that puppy in. It looks like a hot mess, but I got to make it a clean mess. There we go. All right, so my isolation. I'm just gonna go put some caulking over that exposed gum tissue and just around the rubber dam to keep it so I have a nice dry, controlled isolation environment. You can also see that's my X tip that's left in. Sometimes that can get in the way of the bow if you're not paying attention. So always pay attention if you like to do the X tip in the third molar space. Now I'm just taking isopropyl alcohol and I'm just burnishing that caulking in. It sat for a while. I'm hoping for a blood clot to help happen on the other underside of that in the pulp chamber, and seeing if I can actually maintain a dry environment. And if I can, I'm not going to re-access the tooth for right now. This is where I'm going to kind of do something a little bit crazy. I'm going to go right to the sound seal. Now, why would I do that? Well, the main thing is it's a conforming resin, and I'm making the choice right now to bond that puppy into place as you see it, because I don't want any leaks and I want to run the GentleWave. That was my decision. So isopropyl alcohol everywhere, blow it dry. I use a 2-step bonding agent. You can do what you like. And I'm going to, this first step is a conditioning agent. Takes place of sort of an acid etch, and I'm just conditioning the heck out of this thing, and I'm not going to access the tooth. I'm going to basically build it up with blue sound seal. Blow it dry. And I'm just checking to make sure that puppy isn't going to leak on me, because we know that's going to ruin my bond if that happens. So let's apply my layers here. And the dentist already took first round of making the caries removal at his visit with the IRM that punted it to me. I'm kind of removed a little bit more that I thought was affected dentin and kind of took that down a little bit. And now I'm bonding on this stuff. So I'm placing my bonding layer on. And now I'm building up the tooth with sound seal. The nice thing about blocking yourself out with caulking in like a pulp exposure scenario, it doesn't hurt anything to do it. It's easy to remove, but it's a breadcrumb. It's another breadcrumb because it's easy to see under the microscope something white sticking out in a red space. And we saw how hyperemic that was. And so it's not going to be hard for me to re-access this. And candidly, the sound seal is really soft stuff. It's kind of rubbery and gummy and soft. And so I'm not really trying to make a tooth, but I can make the box form of the tooth, kind of guessing where those walls are, just so it visually, when I re-access, it makes sense to my mind. and I'm just making sure that it's pushed up, closing the contact, so to speak, on that distal. I didn't want that rubber dam flipping over it, so I drug my Explorer along that, kind of dragging the cool dam to close the gap there, so there wouldn't be any gaps. I want to make sure I get a good tight seal, so when I run the GentleWave, it works and it's not going to leak on me. And I find this very effective. I haven't had an epic fail like this. It just works, and so I'm just showing you what I do in these compromised scenarios. Okay, so now that that's cured, I'm going to re-access it, and now I'm just pretending it's a normal tooth. I don't care that it looks like a Smurf, but I'm going to re-access it, and I like to find where the white stuff went, just so I can get my borders, and then just do a traditional access at this point. Now, I'm not necessarily worried it's a compromised tooth. You know, it's the Ninja stuff isn't an issue here because I'm making an access into blue stuff, right? There's no tooth structure above it. I just don't want to gouge that floor and or overextend where those canals begin in my access form. But I'm not really worried about removing too much tooth structure because it is what it is. But I have switched to a round burr once I dropped in through the roof, and I'm just sort of finessing it up the walls just to de-roof the chamber and see if there's any pulp stones in there. Kind of hard to tell on the pre-op x-ray, although I find pulp stones almost everywhere all the time, it seems like. And I always remove them. So we'll do a quick little access. I've got a stone over that distal canal right now that I'm actually going to flick up here. Discovered that. Let's just blow it out here. And there you can see I got the 1, 2, 3, the mesiobuccal, mesiolingual, and distal. And then I'm going right to an SX. And I've talked about this before. I consider the SX a rotary explorer. I'm picking at it with it. I don't really care how far it goes. I go to where it just lets me. I'm not going to put a lot of heavy-handed force on that. It's just light. I just go where it goes. I'm not really considering this an enlargement instrumentation as much as just so I can pass another file in there passively. My next go-to file, by the way, is a 1506. Just is what I'm using right now. So I did the distal and the mesiolingual. Now I'm working on the buccal. I'm feeling some tension here. It's not wanting to go in as deep as the other ones did. Probably means that we got a very prominent eminence going down that route. It's definitely angled to the line angle, the mesiobuccal line angle as far as entry goes into that canal. And so, okay, so there we go. I'm going to add a little bit of bleach now. This is in my syringe full strength, whatever full strength is, the Clorox bottle. Let's say it's under 6%. And then I take the 1506. And I've pre-measured this on my cone beam. And I do trust that a lot. I do cone beams on every case. And because of that, I measure on a cone beam on every case. And I try to learn from that. And I play this little game in my head of guessing how right I really was to that original pre-measurement length. And I'm actually having a little bit of an issue now. As I'm going in, this 1506 didn't want to go very far. I went kind of mid-route. And I switched to a 1504 to see if it would go down to my kind of corrected working length. And it kind of didn't do it. It was really hard. And I could feel that file hitting just boom, hitting that brick wall. And that's my timeout, because I've learned now of doing all these GentleWave cases that I'm going to actually employ the GentleWave to help me establish my length. Might be kind of crazy, but I don't want to break a file. And what I've decided to do is that's going through my head. I'm going to one size bigger to see if I can push a little bit harder, if it's a stone or some sort of calcification I can push through. So I did pass one more file, and that was a 2504. Had no problem in the distal. I'm only talking about specifically the mesiobuccal and a little bit further in the mesiolingual, but I know I'm not to my patent length. And I'm guessing in my mind from that measurement, because I was in the 19.5 range, that I'm barely touching 18 right now. And so I'm 1 millimeter, 2 millimeters short. So what am I going to do? I can keep picking and picking and picking, and that can add risk, add entropy. It adds just life can happen along the way, and I can get heavy-handed. My assistant can hand me a crappy file. A lot of things can happen. Patient can sneeze, and I could break something because it's just going to hit. I'm hitting this wall the whole time. So I made the conscious decision to run the GentleWave. So I'm now considering that first sound seal buildup is just tooth. So I put my new breadcrumb in, so my sponge, and I'm just taking that bendy brush and I'm drying it all around with alcohol. I just want it dry just to get a better stick to this surface now. So now I'm doing the platform build. So the first sound seal was not anything to do with a platform other than to rebuild the tooth to give me a nice kind of access, single surface access. And now what I'm doing is I'm making an ugly mud pie, but it's a sound seal mud pie. And then I'm going to kind of cover up the platform matrix, just the intaglio surface of that. And I'm going to connect the dots here. I'm using hemostats. I'm keeping the little notch towards the mesiolingual or mesiobuccal line angle because of convenience form. You can pretty much put it anywhere, to be honest with you. I one time watched Reed Pullen put it towards the distal. I think he likes looking at the distal under a mirror, I guess. But I like the mesiobuccal line angle. And that is just really to help you dislodge it off of the platform after you cure it. The other thing, remember, folks, that these platforms are clear, so you can cure through it, and you're not going to touch it. So I actually like the heat of the light touching the matrix because it just cures better. I'm not afraid to do multiple cures either. It's not a race for me. It's a stability thing for me. Sometimes, as you can see, I'm under that little clamp right now, and that's a scary thing because as you see me kind of trying to make sure I don't dislodge that bolt, could you imagine me trying to remove that sound seal and then breaking it loose and debonding the original sound seal layer because of me not paying attention to that platform? So that angle or how flat you put that rubber dam clamp on is very important because you don't want to get it caught underneath the platform. And if you do your homework or you're a Boy Scout, check that early on. I got lucky right there. And I find that 2AS is sufficient 99% of the time, although that was really close. You saw me remove the breadcrumb. I just take a large, it's actually a 50 profile, a landed file. Remember those? Remember the landed days? And I use it just because it grabs everything, cotton, sponge, whatever, it pops the cork. And then I just do a quick little reaccess. And just because I want to make sure there's no sound seal dust or flashing going down into the canals, you can pass another quick little file through to make sure you're not blocked anywhere. Because the idea is that I make a pathway for the fluid dynamics for the GentleWave. That's what I'm thinking right now. All right. Let's take a look inside. And you can see that that internal sound seal is bonded to the floor on that buccal wall right there. Specifically the mesiobuccal line angle. Because that's where I was encroaching upon it. So because of that, I'm going to pass a file in there and make sure there's just no sound seal on top of the orifice. And then if you get a lot of debris, dentinal mud from that process, just take your syringe back in there and flush it out again. It's what we do. All right, let's get this into focus. Okay. Now it's time to just the depth gauges, the little depth gauge jigs. It started with a yellow. It's touching the floor. Then went to the 9. Or the red. Just flipped my blue out of the mouse, so it's going to give me a new blue. And that was the size I determined. So she put the cap on. Didn't feel the scratchiness along the floor. And I go all tactile here, just because it's really as fast as you're seeing it. So I stopped measuring with probes. I just trust my senses. It's haptic feedback at this point. And put my sealing cap on, and then I let her rip. And, you know, the main thing is does this technique, is it going to hold? And so I'm going to be very conscious of any foaming or bubbles that can come through here. And not through the center, but kind of around the little exhaust tunnels that go around the sound bar is where we're really paying close attention to. And making sure that's fully seated. And we're going to go through the degassing phase right now. I'm watching these bubbles. This is the little exhaust vent right here. And as this is running, you've seen this explainer video every single time, but it's just the cleaning disinfection video explainer that Sonendo has put out. So as you look at it, it goes through their acronyms of what's going on and what their claims are of unparalleled cleaning and all this stuff. Well, as an endodontist, it's our job to employ that and make sure that that's really a reality. And that's still on us, and that's why we're still doctors here. And if you remember, during this case, I said I had a hard time getting to my length and really establishing sort of patency, then that patency principle. I knew I didn't instrument to my working length. I just didn't. I couldn't. I was hitting that sort of that dead end, and that was bothersome. So what I'm doing is I'm going to employ the GentleWave on the extended cycle to see if that helps me get through that, which also means I'm going to have to pass another instrument to confirm that, which is what I'm going to do. Now, through the sound bar, there's always a conversation about where does cavitation occur. And I've got asked this all the time, and it really occurs at the window of the sound bar. So the sound plate is like a dome or a cup, and they've spent who knows how much money trying to figure out the angle of that to redirect the internal stream. But that fast-moving current against a static fluid creates shear force, and that shear force creates the cavitation. So it's happening right at the window of the sound bar. And that's where the little cavitation clouds occur and heat is generated. And also sound is generated there. And then the redirection of the fluid creates an overall vertical flow. And that's what that animation is trying to describe to you, as it's sort of spiraling down the root with an echo of a sound wave along with it. So you have movement of fluid dynamics. You have a slight increase of temperature change, which is also a catalyst for the chemical. And then you have the sound wave, which is another catalyst. So you have agitation, you have heat as catalyst for the chemical activation of sodium hypochlorite. So you get an accelerant going on. You also have fluid dynamics, which are a physical force agitating pulp tissue or remnant debris, dislodging it, if you will, off the walls. And then you have the echo of the sound wave lapsing against the canal. And that's where they get their BAR, their broad spectrum acoustic resonance of the sound that's kind of going down. And it's just essentially white noise as I understand it. And that's what this thing's doing. And it's doing it to do it effectively. It's doing it in a degassed environment. So as we hold this procedural instrument on, I want to maintain that degassed environment. If there's an air leak from my platform build, that environment changes and then the efficacy is not there. So our job now is to actually hold the PI and pay attention to those details and create that environment to employ this energy through the tooth. And I'm really conscious of it because this is a compromised tooth and I don't want to compromise care. And I had a problem with patency at the beginning. Now I'm showing you this. This is the exhaust tube. This is what's capturing around the sound bar as it's flowing back through the procedural instrument, and then it's going through this tubing that goes back into the console and it's collected in a waste canister. And if you ever want to look at it, go look at the waste canister and see all the crap we bring out of these teeth. But it's a true what goes in must come out scenario. And that is done in this negative pressure environment. And that's where you get the suction word, if you want to call it that, or just a negative pressure, which is what is sort of the accepted term. And I'm watching what comes out. Now, sometimes these pulsations that come out through the exhaust tube are hard to identify, and it's kind of a pain in the butt to hold it up here. So I kind of usually just look through the window of the procedural instrument. And a lot of times what I'm looking for is those bubbles, but I'm also looking for red, because that will also tell me that I'm getting patent or established openings into that extraradicular space. And I want to know when that occurs, because there could be a time in a case where you abort. You stop what you're doing if you think that's excessive, and you should stop if you think that's excessive. Safety first, always safety first for the patient. But this is pretty much smooth sailing on this tooth. And my blockage roughly is occurring right here where my arrow is. So from here to here, I know I'm in a little bit of trouble of no man's land, and I want to know what that is. And my wing of my prayer is that I'm going to have fluid dynamics, not leave egg on my face, to have an acceptable outcome of this case. So I want this thing perfect. Now you can't see, but if you, because of where I put the x-ray on this, it's kind of covering the time clock, the timestamp. In a lot of my videos, I'll pay better attention to make sure you always see that time span. I just noticed it's not on this one, so I'll make sure that's on the next one. But you do have the play bar at the bottom of your video. And so roughly we're 24 minutes into this case with everything that I've done. My hope is to get it done under 40, or actually 35. We'll see. So, smooth sailing here. Non-eventful is good during this cycle. Now, the actual physical forces that are happening, the pressure that's coming through, the PSI generated, the speed of the stream that hits the sound bar, that does the fluid dynamic shear force that causes the cavitation cloud, which then causes the bubble, which causes the heat and the echo, etc., etc., etc. That's true of any fluid. It's just when it's a chemical, it can be a catalyst with some of the properties of agitation and heat. So bleach is one of those. So just remember that even if it's in the rinse cycle, it's still using fluid dynamics, advanced fluid dynamics. All right, so finish the cycle. I'm putting some 2004 cones in there. Mind you, the last file I did before the GentleWave was a 2504. And I'm seeing that I'm on those mesials, I'm right around 18. There's my short. And that makes sense. This is really where I like to see on normal GentleWave cases. I wanted to see it roughly, about a millimeter or so, or to, almost full tone of my apex locator. I'm not full toning my apex locator or a patency pullback technique. I no longer do that. I'm trusting the GentleWave, but I'm not there yet. So I'm going to go pass another file through that. You can see my cones crinkled because they're 2 to 1. And you kind of notice that here, the little crinkle bend where it's a little more radio opaque. But now I'm going to just try to see if I can get a file through there. The one thing I've going for me is this is post-GentleWave, so I know that any mud I create is clean mud at this point, and I can still irrigate afterwards. But I'm going to see now, can I get to length with a file? And the idea is this going to, sure enough, there it goes, you saw it. And I went right past that little notch. First notch was 18 millimeters. I can drop into 1504 post-GentleWave down to 20, which is where I wanted to be. It's actually 19 and a half, but you can't tell on by the angle. But there you go. And that's what I've learned. I've learned that, man, it really makes those difficult filing scenarios where we could spend, sometimes multi-visits just trying to establish that apical third. And what I just showed you is I was able to create a pathway post-GentleWave to what we're all probably comfortable, what I've been doing since 2005, and who knows how long you've been doing it, maybe longer. And we pride ourselves in the ability to pre-curve, pre-bend, find files, negotiates down to this perceived terminus that we define as endodontists. And you know what? Is this even possible with the GentleWave? And what happens if there's more than one? Which one are we going to pick? What if there's 10? What if there's 3? Well, all I know is my file is going in one of them. I don't know anything else. Pre-GentleWave, post-GentleWave. If I do it, believe it or not, I don't know. But we know that a lot of teeth have a lot of foraminas. And which one did I find is all I find. But I knew I didn't find any of those suckers before the GentleWave on this case. Now I did the GentleWave. Now I find it. And now I'm happy because I know at least I'm to terminus, I'm to length. I'm going to have my eye candy for my x-ray, and I didn't cut corners. So then I'm going back and I'm actually hand irrigating because I did create smear. If you notice, that paper point came out a little bit pink. I know I'm patent. And now I'm going to obturate. This is kind of really standard for me that kind of obturate a canal at a time. I didn't used to do that. You can see how injected here, the sealer came up here. I saw that before, but I see it all the time with GentleWave. Place the master cone, and whatever comes up this side, what if it's fluid? You know, what if in that isthmus space, it's just the water, or in this case, since I placed bleach in again, bleach. I don't want a salt bleach crystal to form in there. So what I'll do is I'll pack the one side and then wick out that other side with a paper point. And that's something that I like to do, although I jumped to the distal right now. Probably because my assistant told me to. That was a joke, by the way. All right. So just traditional obturation technique. It's a modified continuous wave. I mean, really what I'm doing is I'm just taking my heated element, my hot stick, whatever you want to call it, just into the canal and giving me the ability to push a little bit of apical pressure, followed by a plugger. This is a Buck Buchanan plugger, Buck Pull-Up plugger. And then I'm just going to backfill the top. This thermoplasticize's got to perch on top. If it goes down a little bit far, or if I feel like my heated element took out a lot of sealer, I can reapply sealer. And then just a final down pack. I mean, nothing crazy here. The question is, what did I do in this space and beyond? So, we'll see. 30 minutes into the case. You saw me just rip off that sound seal. It brought both layers. And this is truly bonded in, so I'm taking a little round burr and I'm actually having to remove it. And that's a great thing. That shows you that it withstood kind of the energy of the GentleWave. Again, we know this was a compromised case. No question about that. But it's the patient's last molar. Oh, and by the way, the patient did not want an implant. So the debate is whether the dentist decides to do a bridge off this or just leave an empty space and just get into contact with a single crown, which is actually what I recommended, in hopes that if it bothers the patient, that's an argument for an implant in that first molar site. All right, so now that that's done, you can see everything's clean. I got the blue sound seal off. I'm back down to clean dentin. "31 minutes into the case. And then I'm just taking some alcohol just to make sure I'm removing any remnant debris. Nothing's caught up in a pulp horn or an undercut somewhere. Blow it dry. You can see this, some of that little white stuff came out. Now I'm just going to pack a breadcrumb from my dentist, my sponge. Kind of just hold it in place here. It's always a pain when you're missing 3/4 of the tooth, right? And then I'm just using a temporary material. This is Colposol. It's the name of this product. It's like a cavet. It's white, not pink. Easy to dispense. Assistants like it, so we use it. Patient, fortunately, is heading right over to the dentist for the filling. Now the question is, what would you guys do? Would you put a post in there or not? Comment and tell me what you'd do. There's 1,000,001 ways to build this tooth back to function, so. And I'm just going to smooth it down and take this off, and let's get this cleaned up. Trying not to dislodge the temporary material. Sometimes the best product is your finger to smash it in. Just going to define those outline form of the tooth. Let's take this little X-tip out. And there's my compromised tooth without compromising care. So, moment of truth, I've still got to show you an X-ray here. In all fairness, right? 33, 42 seconds. And there you go. So, you can see where I kind of instrumented pre-GentleWave. This is where I got that 1504 down to, 19 and a half. But look at all these sprouts that came off from that. And that is not something that I took a file into. That is something that clearly was done from advanced fluid dynamics. And it also makes sense why I felt that brick in the canal. So that's what I got for you today, guys. So please subscribe, tap that bell for our notifications and reminders as things come up. You can comment on these at any time, any day or night, at any time. Please comment. Like I said, if I misspoke, correct me. If you have questions that I can't answer, I will respond to it, or find somebody smarter than me to respond to it if you have questions about this procedure. So thanks again for attending, and till the next time.